Uh, Good evening, friends. So today we will be discussing recent advances in ENT. See, ENT is a fast-changing line, fast-changing specialty of medicine. And over the last 2 or 3 decades, due to the technological advancement, ENT is perhaps the fastest growing specialty of medical sciences. And there is a lot of recent advances in the last 2 decades. Now, from the perspective of your examination, recent advances in ENT is very important. You will encounter questions in the theory paper. You might encounter some OSCE questions. And in the oral examination, which is 15 marks for each table, generally one table of recent advances is kept. One is ear, nose, throat, and the fourth one is generally a recent advances. So I have tried to cover as many topics as possible, but sky is the limit. It is not possible to cover. I have been allotted 2 seminars, so it is not possible to cover everything. So what I have done is topics which are already present in the standard textbooks like functional MRI, PET scan. This is the list, image guided surgery, USG, that is available in Scott Brown in a very lucid manner. There are boxes to enable you. You can make notes from that. But then there are certain topics which are not in a very structured manner covered in these standard textbooks, may be Cummins or Scott Brown or this thing, or say Stelmaran. So I have tried to cover these topics. These are basically the recent technological advances, and all the trainees who are going for the exam should know, because one time or the other, most of these topics have been given as question either in theory or in they might have encountered, some examinees might have encountered in the OSCE or even in the practical. So before I launch on to my topic, I'll give a disclaimer. See, I have used many certain images, and these images have been taken from some sites of manufacturers, and you will find the name of the manufacturer written on the image, but there is no way out, because for example, TAUS, transoral ultrasonic surgery, now it is being only manufactured by Olympus. So if I take any image from there, so it will have the image. So I've got no commercial or other interest involved in reproducing these images. These are solely for the better understanding of the topic by the audience. Now, first of all, we come for a narrowband imaging, which is coming in a very big way over the last 7 or 8 years in our country. You will find that narrowband imaging has come in a big way. What is narrowband imaging? So simply put, in the definition, it's an endoscopic imaging technology where light of specific blue and green wavelength is used to enhance the details of certain aspects of the surface mucosa by using special filters in the light system. So this is a light system. This is a light system. And in this, there are certain filters have been placed. See, normal light source has got a white light. So the difference between this light source and the white light system, say any LED or a halogen light or a xenon light, it will emit a white light. Now, in this NBI light source, there will be certain filters which will filter out certain wavelengths of light, and it will allow only certain wavelengths to pass through. It is also known as a biological endoscopy technique, because this is a light source. You are going to use it with an endoscope, and it will help you, the light source will help you to appreciate certain things, which I'll come to later. So it is known as a biological endoscopic technique. So how does NBI work? How does narrowband imaging work? See, light consists of a number of wavelengths. You must have read VIBGYOR in your school: violet, indigo, blue, green, yellow, orange, red. Okay, from lower wavelength to a higher wavelength. So only a small section of this wavelength is visible to the eye. The human eye perceives light within this section as colors. So violet, indigo, blue, you perceive it as colors. Once an object is illuminated, then some colors are absorbed and some are reflected. That holds true for any tissue. So if you put in an endoscope, there will be some light which will be absorbed by the tissue, and there will be some which will be reflected back. So the reflected colors are the ones that we see. So white light comprises the full spectrum, as I said, of the Vibgyor. So when using white light endoscopy, a large number of wavelengths are emitted from the endoscopy. So what happens when you switch on? See, this light source has got a switch by which you can switch on. It has got a white light, this light source, the NBI light source. So it has got a normal light source, and this is the NBI switch. So when you want to switch over from the normal white light endoscopy to the NBI endoscopy, the filter will be activated. So what happens is that there is a narrow band filter which is placed in front of the white light. So this is your white light containing all those spectrum of light. So there is when you have switched on that NBI light button, so only two lights wavelengths will pass. One will be 415 nanometers, which is the blue light, and one is the 540. Now, why only these two wavelengths have been taken? These two wavelengths have been taken because hemoglobin absorbs these wavelengths the maximum. So how does it help you? So when you have placed the filter, now you have switched on the NBI filter. So some of the blue light will be reflected from the mucosa, and some of the blue light or the green light will be absorbed by the blood vessels. So now when there is a pari passu with the reflection of blue and green light and the absorption, and remember in this, the vessels are absorbing much more than they would have absorbed had you just put a white light. So the delineation of the structures will be better. So this is the normal endoscopy which you would have done, a laryngoscopy you would have done with a white light. But when you have switched on the NBI filter, it becomes more clearer. The picture becomes more clearer. You can see the blood vessels. These green and blue areas are the blood vessels. So as I said, NBI light is absorbed by the blood vessels but reflected by the mucosa. In effect, there is a sharp contrast between blood vessels and the surrounding mucosa. This facilitates the detection of the tumor, which are high. See, whenever there is a tumor, there is a high vascularization of the tumor, especially on the surface. So what happens is that thing stands out. That thing stands out, and you can easily visualize a tumor. So the longer 540 nanometer NBI green light penetrates in the deeper tissue. So you can visualize the deeper aspect, slightly deeper aspect, the submucosa part of the tumor, and the surface mucosa is the blue light because it is a shorter wavelength light. So you can visualize the mucosa and the submucosa in a better manner as compared to had you used just a white light with all the spectrum of wavelengths. So just to give you an example, the visualization of capillary system of the lesion is less blurred or distorted as compared to white light. See, here you can see this is white light. Here you can see the lesion. There is no doubt. Very high resolution camera has been used for taking this picture. But when you switch on the NBI filter, the resolution, the demarcation of the blood vessels and the superficial capillaries, etc., have increased much more as compared to a white light. So what are the uses of NBI in ENT practice? So see, early detection of pre-malignant and malignant lesions of the upper aerodigestive tract. What happens is when you are doing endoscopy with a white light, at that time, all the wavelengths are there, and it may, if there is a pre-malignant lesion, it may not stand out. 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 But when you switch on the NBI filter, the lesion stands out. The lesion becomes more prominent because the surrounding area does not have that much of vasculature, whereas the area of pre-malignant lesion or malignant lesion has got more vasculature. So when you have switched on the NBI filter, the green and the blue light will enhance that area, and it will help you to sort of suspect that there might be some pre-malignant or a malignant lesion. Now, taking targeted biopsies, this is relevant in Barrett's esophagus. It is also equally relevant for all the lesions of the head and neck region. Classically, it was the targeted biopsy uh, was sort of described for Barrett's esophagus, but it is not limited to Barrett's esophagus. Whenever you are doing a biopsy, either with a fiber optic bronchoscope or with a rigid bronchoscope, if you switch on the NBI light source, you can take a biopsy from the suspected area. You must have observed when you take biopsy in your school, in your institution, sometimes the the biopsy that comes is not from a representative area. But if you do it under NBI guidance, because now the lesion has stood up, it has become more marked, it has got more contrast than the surrounding normal tissue. You can easily take the lesion, take the biopsy from the suspected site. To detect early residual or recurrent disease in previously treated cases of laryngeal and hypopharyngeal malignancy. See, in the residual and recurrent diseases, sometimes it is not possible to sort of visualize by using this white light, but a residual or a recurrent disease again will show areas of vascular enhancement, and that can be easily picked up by the narrowband imaging system. Now, cancers of unknown primary, you know that. So sometimes what happens is that there is a secondary in the neck. You don't have any, you cannot see any primary in the aerodigestive tract. So to be doubly sure that there is no lesion in the aerodigestive tract, you can just use the NBI. So if there is any lesion which is not visible on the white light, that you can detect with NBI. And even with NBI, if it is not detectable, then it is truly a unknown primary. So other non-ENT uses are to detect the abnormalities of the G junction like Barrett's esophagus, stomach malignancies, malignancy of the colon. So what are the uses of NBI, narrowband imaging? It is the better delineation of the resected margin during transoral laser microsurgery for early glottic cancers. So when you are doing a laser transoral surgery, say you are doing a cordectomy, say. So whether you have excised the margins, you have taken some the margins, it is the margins have been taken properly or not. You can do it with a switching on the narrowband imaging mode of the white light, and you can see whether there is any suspicious area that you may have left behind while doing the say the 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 cord excision, the cordectomy. For preoperative and intraoperative assessment of early laryngopharyngeal malignancies, as I said earlier, it being superior to white light endoscopy, and it evaluates new angiogenesis. This is very important under the cover of slough and edema during post-chemo radiotherapy period, where PET scan or even diffusion-weighted MRI may not be able to detect persistence or recurrence. See, what happens is that sometimes you will find that there is some slough or edema on a post-chemo radiotherapy patient. So that will not be picked up by an MRI or a PET. That might not be picked up by a PET scan. So if you do but then if there is some suspicious area, some malignancy below that slough, that there will be new angiogenesis in that. That can be picked up by narrowband imaging. Now, there are certain limitations of narrowband imaging. This is that it is difficult to interpret NBI findings in post-irradiated oral and oropharyngeal malignancies. Why? Because of the inflammation. So if there is inflammation, even that will give you a highly vascular sort of an area, and you may not be able to sort of differentiate whether it is due to the inflammation or whether it is due to some recurrent disease or residual disease. Some false positive cases may occur commonly in post-radiotherapy, ulcers, infections, and laryngeal papillomatosis. And positive chances of false negativity is also there in submucosal pathology because it is not showing. Because see, what I told you was that in the narrowband imaging, the mucosa and just the submucosa is visible because that is the area from which the green and the blue light are either being reflected or being absorbed. So sometimes submucosal pathology may be missed. So that may be a false negative case. And in non-squamous cell carcinoma, which may not have that kind of a vascular pattern as a squamous cell carcinoma. Now, next, we move on to the next topic. You must have all heard about the transoral robotic surgery. Short form is TORS. So this is the setup of TORS. You must have all seen it on the, at least on the net. So what is transoral robotic surgery? So it is a specialized, you know that robots are coming in a big way. So even in ENT or in surgery, robots are coming in a big way. So it is a specialized robotic technology that enables a transoral safe access to treat hard to access areas at the back of the throat, areas like base of tongue, hypopharynx, supraglottis, etc., as also the skull base lesions. See, you know that base of tongue, hypopharynx, you encounter a case in the base of the tongue or hypopharynx, in invariably your consultants might say that, oh, you send the case for chemoradiotherapy or something. Surgery is very difficult. It is very mutilating. There is lots of morbidity involved. You might have to do a sort of a mandibulotomy approach. So generally, these cases end up getting a treatment by chemoradiation or radiation or whatever. So, but transoral robotic surgery helps us to excise these lesions also. A surgical lesion, if it is the first choice, if it is the first choice of a lesion, if it is the first choice for the first modality of the treatment, so why should you compromise on that? Why should you send it because it is a difficult to access area? You can easily go in for a transfer, of course, if the facilities are there. So the technology or the system of depends upon these three main structures. The endoscopes, which are flexible endoscopes attached to the robotic arms, special camera at the tip of a robotic arm that I'll come to the diagrams later on, provides enhanced use of the surgical field, and a computer console where the surgeon manages the instruments and cameras every movement. So, 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 so the how does this TOR system work? Uh, See, the Da Vinci was the first system that came. Now there are one or two more systems that have come. So it consists of a central arm which has a high resolution camera. I'll switch to the next, next picture. I'll come to that later on. Then two side arms which serve as a working hand. And surgeon sits at the console from where he controls the movement of the working hand instruments. So this is a setup of the transoral robotic surgery OT. So here you see, here is the actual surgeon. He is sitting so far away from the patient. So had it been a traditional surgery, he would have been on the right side of the patient operating. Here he is sitting comfortably on the console, on a computerized console, and he is controlling everything that is happening on the patient. So this is the assistant, the nurse, this is the all the cards, the endoscope, and this is the surgeon's control. The anesthetist generally sits at the foot end. And there is no hindrance to the surgeon or the assistants in his or her work. So these are the TOR system components. So as I said in the earlier slide, this is the endoscope. Endoscope, you will insert the endoscope through transorally, and there is a system, there is an arm which carries the endoscope. So you can see the camera and the light, sort of light, this thing, light cable and light fibers. And this is the robot. These are actually controls of the robot. This is what the control of the robot looks like. So the surgeon is basically what he is doing. He is controlling it with his fingers and wrist mainly, or the arm. And these are the instrument hand. See, an analogy has been done in this picture with a hand of a human being. See, the hand of a human being has got a lot of, movement, so 360-degree movement. Sunny, I am in a lecture, please don't. So, so this is the So this is the 360-degree rotation. So what is the main advantage of a transoral robotic system is that the dexterity of the hand, the arm, the robotic arm, it gives a lot of, agility, mobility. So you can enter. See, I told you this is for base of tongue, especially suited for places like base of tongue, supraglottis, hypopharynx, places which are very difficult to access by open surgery or even transurgery. But with a robotic arm, see, if this is the amount of movement, just as the wrist of a human being. So you can see how much of movement there is. So it affords this facility, this advantage to the surgeon. So these are the energy instruments which are used uh, with a transoral oral robotic surgery. Includes things like bipolar forceps, then there is a dissector, then there is a monopolar cautery. So this is the operative field in which basically the surgeon from the console is, he is controlling all this robotic arm and he can go to precisely to the area where he wants to operate. So this is a picture of the robotic arm. Here you can see there is the camera is in between, and there are these are the energy instruments, the monopolar cautery or bipolar, whatever. And these are the instruments which can be used for any cutting or any other surgical uh, uh, surgical activity. And this is the central console, as I told you earlier. And for a TOR surgery, for a transoral robotic surgery, you need very good retractor because you are entering a blind spot area like base of tongue, hypopharynx. So you need a good retraction so that at least you can enter the robotic arm, the various endoscope and the instruments through the oral cavity. So you need good retractor. So this is a typical example of a TORS retractor. And this is the TORS retractor in place. So what are the application of TORS in ENT? It is used as an alternative to chemoradiation. As I said earlier, in your institution, you must have observed if there is a case of a base of tongue, you will invariably send him for a chemoradiation or a radiotherapy or something like that. So with a robot, you need not do that. See, there are instances, there are cases in which surgery is the first choice and chemoradiotherapy is done because we cannot exercise the first choice due to some reason or the other. The If you have done a chemoradiotherapy on a patient, which should have ideally gone in for a surgical option, the problem that happens is that if there is a recurrence and you want to do a repeat surgery, it becomes very difficult to operate upon an irradiated patient. So it is an alternative. So you can exercise your option for surgery with a transoral robotic surgery. And you can avoid traditional open surgeries also, which involves a lot of morbidity. So, which are the areas in which you would be doing TORS? These are the oral cavity, the oropharynx, hypopharynx, larynx, piriform sinus, intertemporal fossa, and the skull base. Now, non-cancer uses of obstructive are in obstructive sleep apnea syndrome, obstructive sleep apnea surgery for the removal of tonsil, adenoids, uvula, edge of the uvula, and or part of the base of the tongue. What is the advantages of using a transoral robotic surgery? See, 360-degree freedom of rotation of robotic arm. The भाई साहब एक प्रेजेंटेशन में हूँ, आप बाद में रिंग कर दीजिए. See, it avoids the potential long-term toxicities of chemoradiation. As I said, that in a base of tongue, you are sending the patient for a chemoradiation where maybe a surgical option was the better choice. So you could not do that because you didn't want to give the morbidity of a mandibulotomy approach or a very open, very sort of a radical sort of a open surgery. So it this TORS avoids this potential long-term toxicities of chemoradiation. So you can exercise the surgical option in these cases. So it avoids the morbidity and complications associated with highly invasive open surgeries. It avoids the need for extensive, yes. Now see, you are directly targeting the area of your interest, like the base tongue. So, or the supraglottis. What happens is that in open surgeries, if you sort of excise the, say, larynx or the uh, supraglottis, you might have to go in for some sort of a reconstruction, which is not required. Also, you may require a mandibulotomy, for example, for the oropharyngeal lesions, for the base of tongue lesions, which is not required in this case. So an external incision would be avoided because whatever you are doing approaching via the oral cavity. So decreased blood loss, the blood loss will be much less as compared to a open surgery. Decreased rate of post-operative infection because you have not exposed the tissue as much as you would have done in an open surgery. It is safe and effective, and it is shorter hospital stay because the morbidity is less, so there will be a shorter hospital stay. So certain complications are there, but those are very minor, like dehydration, injury, bleeding, dysphagia, dysgeusia, uncontrolled pain, and rarely you may encounter hemorrhage, deep vein thrombosis, pneumonia, pulmonary embolism, death. So what are the disadvantages of TORS? TORS. So biggest disadvantage is high cost of the equipment. See, if you are going in for a transoral robotic surgery system, this with its consumables are also very expensive. The consumables may cost something of the order of 30 crores or 25 crores, which is not easy for everyone to afford. So it is the high cost of the equipment, high maintenance. It requires a high maintenance cost, expensive consumables. Another thing is the absence of tactile feedback. When you're doing open surgery, you are either using some sort of a instrument, cold steel instrument like a, say, a scissor or a forceps. So there is a tactile feedback. You won't get a tactile feedback, a feeling feedback, uh, a touch feedback in this surgery because the surgeon is sitting remotely on the console and the on the robotic arm is doing all the work. So it is not possible to get a tactile feedback. Then per operative, now this can be very disaster if the robotic system fails during, though it is rare, during this surgery. And then there is a very steep learning curve. You have to there are fellowships in transoral robotic surgery, and even after a fellowship, it will take some time for you to learn the nuances of the surgery. Now we come to the next system. This is transoral ultrasonic surgery in ENT. So what is transoral ultrasonic surgery? See, what happens is that even this is a very good alternative to transoral, very good and cheap alternative to transoral robotic surgery. There are one or two limitations, but then it is almost as good, as transoral robotic surgery. The only thing is that TORS is here for the last many years, say 15 years or 10 years, 10, 15 years, whereas the short form of transoral ultrasonic surgery is TAUS. TAUS has come for the last, say, 5, 7 years only. So it has been now only Olympus, I'm sorry I'm using this, but you should have the knowledge that only Olympus company is making this thing, this equipment, this system. So what is TAUS? A minimally invasive organ preserving endoscopic approach for benign and malignant tumors of the upper digestive tract using ultrasonic energy. This is ultrasonic energy. And it uses an ultrasonic scalpel as a dissection tool, as a cutting tool, and advanced bipolar energy as hemostatic tool. So two energies are used in TAUS. One is the ultrasonic scalpel, the ultrasonic energy, and another is a advanced bipolar energy. The combination of the two helps you to cut the tissue and to seal the vessels, to do hemostasis. And mind you, vessels up to 7 mm can be sort of controlled with this advanced bipolar energy system. So mind you, this is basically the advanced bipolar energy is the bipolar that we generally use. It is not ultrasonic. The ultrasonic scalpel is the other component. So what are the indications of TAUS? This is almost like, say, your TORS. This is lesions of the soft palate and tonsil, lesions of the base of tongue, posterior and lateral wall of the oropharynx, lesions of the hypopharynx, piriform sarcus, and partial and total laryngeal surgery. Mainly, these are tumors, benign or malignant. Now, what is the technique? How it is done? Just I'll show you some pictures how it is done. So the placement you can see here is almost like TOS. Only thing is that the surgeon is actually instead of the console, because here there is no console. The surgeon is actually hands-on the head end of the patient, and the ultrasonic scalpel is at the foot of the patient, and here is the monitor. So the surgeon is looking into the monitor and he is operating. So this is the endoscopy tower, and here sits the endoscope. Now, as I said in the TORS section also, you need a very good sort of a retraction mouth opening, because you will have to enter all sorts of endoscopes and instruments into the through the oral cavity. So this is the laryngopharyngoscope. It is called the FKWO retractor. It creates a pharyngolaryngeal space by retraction of the base of the tongue and supraglottis. And there are innumerable number of blades depending upon the site on which you want to operate, whether it is the base tongue, whether it is supralarynx, supraglottic larynx, whether it is the tongue. The blades will depend upon that. So this is how the setup will look like when you have set the system. So there is an arm holder here, and this is the retractor, FKWO retractor, which opens the mouth. Now, it works by an endoscope. So how does this endoscope work? See, the specialty of this endoscope is it is a rigid endoscope, but the tip is flexible. So what happens is that at flexible tip, you can control there is 110-degree flexibility. So here he is looking down. So suppose if you want to look up, you can tilt the tip of the flexible endoscope upwards. So you are getting an all-round picture of the area you want to operate. So let's come to the next. So this is the endoscope with the flexible tip. It is called the Endo-I Flex by the manufacturer. And you can see this tip, this is flexible. 110 degrees of rotation is allowed in 4 directions. In 4 directions, the tip can be rotated in 110 degrees. So that gives a lot of sort of agility to you or a vision to you. You can, wherever you want to operate, you can sort of take the tip of the endoscope to that area. So this is the energy cutting and sealing instrument. It is called the Thunderbeat by the manufacturer. This is the ultrasonic basically instrument which is used for the cutting purposes. So these are the various instruments that are used in conjunction with a TAUS system. So this is monopolar, cautery, bipolar, then there are the radio frequency electrodes, and these are the other instruments, cutting instruments that are used, claspers, dissectors that are used in a TAUS system. Now, another thing was that, I'll comment on the advantages. Yes. So one is that it is safe. It is safe compared to, say, what a open surgery is like. It avoids the morbidity which accompanies open procedure, especially intended for patients previously treated with chemoradiotherapy. As I said, once the patient has gone into a chemoradiotherapy, it becomes difficult to operate. But with a TAUS system, it would be, even a chemo-irradiated patient would be it can be easily done. The surgery can be done. And faster, it affords a faster resection time, of course, than an open surgery. One important aspect is that intraoperative assistance with a narrowband imaging can be done in these cases. So as I said in the narrowband images, if you have got a suspected lesion, so when you are inside with the endoscope, with the flexible tip endoscope, if you switch on the narrowband imaging switch, so you can easily see which area is the offensive area, and you can precisely excise that area. It is a more affordable alternative to TORS. I do not know whether I should be giving you the rates, etc. But a TAUS system would cost less than a crore of rupees as compared to TORS, which would be costing many crores. So it is a far more affordable alternative to TORS. It has got a faster learning curve than TORS. It is much easier to learn a TAUS rather than a TORS. Then there is a bloodless resection, optimum view of the lesion through use of magnification and high definition cameras. You can combine it with magnification and high definition cameras, and there is a faster recovery than the classical procedures. Now, what are the limitation? Limitation is that all said and done, a robotic arm will still have more of flexibility and rotation as compared to the TAUS flexible tip endoscopes. Now we come to the next session, that is the temperature controlled radio frequency ablation, commonly called the radio frequency ablation, but the full name, if you want to do it properly, if you want to name it properly, is temperature controlled radio frequency ablation. TCRFA is the short form. So what is TCRFA? What is temperature controlled radio frequency ablation? It is a minimally invasive technique that allows the surgeon to deposit specific amount of low temperature, low voltage energy in the form of radio frequency to a specific site. The goal of radio frequency ablation is to induce thermal injury to the tissue through electromagnetic energy deposition. The term radio frequency refers not to the emitted wave, but to the alternating electric current that oscillates in this frequency range. See, what happens is that the cutting or whatever ablation, whatever is happening, it is because of the changes that is being induced in the tissue by the current that you are passing by the radio frequency ablator. So I'll explain it. So how does this work? So there is a needle, a probe, just like your say cautery probes or radio frequency needles. So a radio frequency needle on being inserted and with the switching on of the current of the radio frequency, a coagulation of the tissue is achieved by the electromagnetic energy source with frequency range of less than 900 kilohertz. In monopolar mode, the patient is in the monopolar mode of this RFA. Now, RFA also works in a monopolar mode or in a bipolar mode also, and in a uh, hybrid mode also. So, in a monopolar mode, the patient is in the form of a closed loop circuit. So, what is this closed loop circuit? It includes the RF generator, the machine, the radio frequency machine, the electrode needle, and the large dispersive electrode or the ground pads. Ground pads you must have seen when you are placing a cautery in a monopolar cautery, you always place the ground pad. So that that makes up the circuit. So what happens is that an alternating electrical field is created within the tissue of the patient. So when you have inserted the needle and you have switched on the radio frequency, so an alternating current field will be created within the tissue of the patient. Because of the high resistance compared to the metallic needle, there is a marked agitation of the tissue ions in the target tissue. Basically, what you have to remember as students is that there is a basically, due to the radio frequency, there is an agitation of the tissue ions in the target tissue that does the work for the radio frequency ablator. This agitation, this ionic agitation, causes the tissue to heat, which heats only up to the temperatures of 60 to 90. Mind you, lasers, electrocautery, they are working at 750 degrees centigrade. Whereas a radio frequency ablator, it is working only at 60 to 90 degrees centigrade. So what happens at this temperature? The protein of the tissue denatures. Even at 47 degrees centigrade, the protein starts denaturing. So when you are given a temperature of 60 to 90 degrees, so this protein will denature. Whereas when you are using a laser or an electrocautery at 750 degrees centigrade, the tissue will basically burn. You are burning the tissue. Whereas here the protein is getting denatured. This is the difference between the radio frequency. So due to this denaturing, there is an acute inflammatory response which sets in within the first 24 hours, leaving the tissue congested and irritated. So when there is an inflammatory response, you know that due to an inflammation, there will be congestion and edema. So that happens within the 24 hours. And by 72 hours, the treated area undergoes tissue necrosis. And by the 10th day, a fibrosis sets in. So what is the ultimate goal of using a temperature controlled radio frequency ablator? It is tissue reduction done in two stages. One is contraction and other is resorption. Initially, an area of fibrosis contracts and puts the adjoining tissue with it. So that causes the contraction. And subsequently, over the next few months, blood resorbs in this area, and it causes a further volumetric reduction of the tissue. So as I said, tissue reduction done in two stages, contraction and resorption. Now, what are the application of temperature controlled radio frequency ablators in ENT? Snoring is the most important. Snoring surgery, sleep surgery, obstructive sleep apnea surgery is one of the greatest indications of radio frequency ablator. So how is it done? There is a thing called channeling of the soft palate. I'll come to you by means of diagrams in the next few slides. And what does the channeling do? Channeling do. I'll show you the diagram so that it is clearer to you. See, what is channeling? Basically, what happens is that you are passing this radio frequency probe submucosally into the soft palate or tongue base, and then when the current is switched on, that sequence of event I said of first an inflammation and then a retraction and sort of a uh, resorption takes place. So channeling of the soft palate and tongue base causes a stiffening and contraction leading to a reduction of obstruction in the airway at the palatal and the base of tongue level. If the only negative part is that this effect of channeling of the soft palate, that is passing of the radio frequency current, it wears off after some time, say 1 year or 2 years. So you might have you need to sort of repeat these sittings of channelings. Then next is the volumetric reduction of inferior terminates associated with nasal obstruction and snoring. Tonsillar hypertrophy. See, tonsillar hypertrophy, generally what you do is you tend to excise the tonsils when you are using either a cold steel or a bipolar or anything you are using. But here you can do a submucosal intracapsular volume reduction of the tonsillar tissue. It is safe and effective modality to treat airway obstruction and in reducing snoring and mild cases of OSAs. You need not remove the tonsil that we traditionally do is an extra capsular tonsillectomy in which we are basically along the capsule, we are removing the whole of the tonsil. Whereas in these cases, you do a submucosal tissue volume reduction. So that is good enough for the airway to clear. Basically, your aim is to increase the space in the airway so that you can so that your air goes inside properly in the airway. So then there is a combined application of radio frequency to soft palate, tonsil, and tongue base. Now this can be it is an effective modality in the treatment of snoring and mild OSAs, and for this is for mild OSA. And if there is a higher stage of OSA, UVP may be combined with all these, radio frequency application to the soft palate, tonsil, and tongue base. So these are the applications of in a pictorial form. This is the tongue base radio frequency ablation. This is the soft palate. This is the sort of the inferior turbinate volumetric reduction of inferior turbinate. This is a submucosal or a intracapsular tonsillotomy that is being done. So what are the complications? These are very few and not very sort of serious complication. These are superficial ulceration of the soft palate at the area in which you just entered the soft palate with your probe. Mucosal breakdown. There might be neuralgia of the tongue base, and rare, which however may cause a compromise of the airway, is base of tongue abscess, tongue hematoma, floor of mouth edema, or tonsil abscess. But then these are rare complications. So next, we move on to the next section of our presentation of recent advances, that is coblators in ENT. So what is coblation? Simply put, is this cold ablation. So cold because low temperatures are achieved in this, and ablation because it ablates the tissue. It does not burn or char the tissue. So definition is it is an electrosurgical technique which employs an oscillating electrical current to disrupt surrounding tissue using radio frequency energy in a conductive medium, usually normal saline. It is also referred to as electrodissociation procedure. See, we just discussed radio frequency ablation.
You have to understand in coagulation, radio frequency energy is also being used, but then there is a difference. There, the radio frequency in a radio frequency ablator system, the radio frequency energy is being directly put to the tissue. Here, it is not being directly, the energy is not being directly put into the tissue, but then there is a conductive medium in between, which is the normal saline. And the work is done by the dissociation of normal saline and the ionic oscillation of the sodium and the chloride ions. So how does coagulation work? So this is a very complicated diagram. You would get confused, but still I have put this diagram. Electrodes at the tip of the coagulation probe serves as the source of the radio frequency energy. As I said, that even a coagulation works with a radio frequency energy. Now, what radio frequency does is that radio frequency energy excites the conducting medium, which is the saline solution. A field of electrically active sodium ions is created. This plasma has enough energy to dissociate the surrounding target tissue molecular bonds. And since there is a continuous flow of saline from the probe tip, the system generates a relatively lower target tissue temperatures. Now, let me come to the diagram. Otherwise, you won't be able to understand. See, what happens is that this is the coagulation probe. It is known as the coagulator band. And the tip has got these three electrodes for delivering the radio frequency energy. And there is a suction channel here, and there is an irrigation channel. So what is happening is whenever you are switching on the machine, and you have to connect it to a sort of a saline bottle, and you have to connect the other the suction channel to a suction machine, a good suction machine. So as soon as you switch on the machine, the radio frequency energy will be coming out of these electrodes, and at the same time, the saline will be there in the field, and at the same time, so that this field does not get sort of flooded with saline, otherwise your vision will be hampered. So there is a suction also. So when there is a saline and when this radio frequency energy hits the saline, a sort of a this uh, sort of a sequence of events happens. So you have put the bipolar radio frequency energy, it flows through the normal saline. Now normal saline breaks into sodium and chloride ions. And what does it do? It contains a thing called a plasma field. This is the plasma field is the thing which is basically ablating or cutting the tissue. So what does this plasma field do? What this sodium and chloride are now these activated sodium and chloride ions, what does it do? It basically breaks the organic molecular bonds of the target tissue, and that causes the dissolution of the soft tissue. So this is the mode of working. So earlier in the radio frequency, we said that it was basically a sort of a ionic AC current was being produced, and it was the agitation of the ions of the target tissue. Whereas here a plasma is created, plasma field is created due to the breakage of normal saline and sodium and chloride ions. And these sodium and chloride ions are actually causing this organic molecular breakage. Coming back to the slide where I was, and this I said that since there is a continuous flow of, because a coagulator will work only if there is a saline. So since there is a continuous flow of saline, there will be the temperature that will be generated will be very low. It will be of the order of 40 to 70 degrees. Whereas, as I said, it is almost 700 degrees centigrade for a traditional electropottery machine. So the collateral tissue damage, you can understand, will be much less. So this I have explained already. So this is the coagulation band. The saline is being, there is a irrigation of saline here. So this is generating a plasma. What is the plasma? This is basically the activated sodium and the chloride ions, the breakage of the saline, the sodium chloride in the saline. And this plasma is doing the work of ablation or cutting or whatever it is being used for. So I have done with this slide. So what is the advantage of coagulation over a conventional electrosurgical device? Temperature, as I said, it is 40 to 70 degree, and in conventional it is 400 to 600. It may go up to 700 or more. Thermal penetration is much less as compared to A conventional, it is 2200, 2200, where it is 100, 110, 1100 nanometer. And uh, the effect on what is the effect on the target tissue? That there is a gentle removal and dissolution, whereas in a conventional electrosurgical device, there will be rapid heating, there will be charring, there will be collateral damage, there will be burning, and there will be cutting. So, something about the historical aspects of coblation technology. It was discovered by Phillips and Eggers and Hira. This thing initially developed for treatment of arterial blockage. It was first developed by ArthoCare in mid 1990s, and it was ArthoCare developed it for cartilage repair in arthroscopic surgery. Now, what are the ENT applications of collated technology? It is almost as the same as the radio frequency ablators, tonsil removal, whether extracapsular or subtotal intracapsular, volumetric reduction of inferior terminates, snoring and oasis surgeries. Here also you can do soft palate, and there are special probes of coaglators which can do a channeling procedures. And in nasal surgeries, if you use it in juvenile nasopharyngioma, your life will be much easier because the bleeding will be much less. In a coagulator, the bleeding is much less than when you use a traditional sort of a open surgeries. What are the advantages of using coagulator technology? It works at much lower temperatures and frequencies than conventional electrocautery, less tissue destruction and collateral damage, faster wound healing, less post-operative pain, and coagulation probes also allow for hemostasis through coagulation option. There is a coagulation option also in coagulation probes. Now, disadvantages and shortcomings of coagulator technology is that extensive equipment. It is an expensive equipment. Something, say, a coagulator nowadays would cost something like, uh, I think, 10, 12 lakh rupees. And the bands are single-use bands, or probes are known as bands. And these bands are also of the, say, 20, 22,000 rupees. So for one patient, you end up spending 20,000 of consumables for one patient. So these are expensive probes and bands, steep learning curve. So it is not an easy thing, especially for a tonsillectomy. It is not easy in the first go to achieve a proper tonsillectomy with a coagulator, and higher incidence of secondary hemorrhage after tonsillectomy. This is true for all intracapsular tonsillectomies, because you have left behind some tissue and there is a chance that there may be some secondary hemorrhage, secondary infection after 5 to 7 days, and that may cause secondary hemorrhage. So next I come to the computer-based. This is my last section of this sitting. This is cone beam computed tomography. This is also, I've included this also because basically it is the dental department's forte, but CBCT is now being done for the ENT indications also. And besides, you might encounter some theory question or some Viva recent advances, you might encounter some questions, so I have included this. So what is cone beam CT scans? Cone beam CT scan is a variation of the traditional computed tomography. So generally what you are doing is basically a CT scan you are doing. In cone beam, what is happening is that unlike in traditional CT scan, in cone beam, an X-ray tube and a detector panel rotate around the patient, capturing data with a cone-shaped X-ray beam instead of slices. In a traditional CT scan, what do you do? Basically, a gantry rotates around the patient, and in a fan-shaped manner, it projects the sort of rays, the electromagnetic, the X-ray rays on the patient to get a slice sort of a cut, slice sort of a slice cuts uh, in the sagittal or coronal or the axial planes. So in cone beam CT, it is being done in a cone-shaped manner. The projection of the X-rays will be in a cone-shaped manner. So what is the usefulness of that? So basically, a cone beam CT, the main advantage is that the radiation is much less. There are patients, for example, some cancer patients or some other patients which you want to give less radiation.
cone beam CT, the basic advantage is that you are giving less radiation to the patient as compared to a traditional CT scan. The images are reconstructed using algorithms to produce three-dimensional and of course two-dimensional also at high resolution. How does what are the components of a CBCT, cone beam CT? Consists of an X-ray source and detector mounted on a rotating gantry. During rotation of gantry, the X-ray produces divergent cone-shaped radiation. Now, this is the most important thing. There is a cone-shaped radiation, while receptor records the residual X-rays after attenuation by the patient. That is true for the conventional CT also. I'll show the diagram in the next slide. In fact, let me show you. See, this is the X-ray tube in which you have sort of, in a cone-shaped manner, you are basically projecting the X-rays. Whereas in the what happens in the conventional spiral CT is you are doing it in this manner. It is in a fan beam manner. So you can see the radiation is much higher, and it will be to areas which you actually do not want. These are not the target areas. Radiation happens to those places, to the surrounding places also. Whereas in a cone beam CT, the radiation is happening only to the area of my interest. Whereas in fan beam, the radiation is much more. As I said, that the main advantage of a cone beam CT is that you get a very less amount of radiation. The patient gets a very less amount of radiation as compared to a conventional CT scan. So during rotation of the gantry, the X-ray source produces divergent cone-shaped radiation, while receptor records the residual X-rays after attenuation by the patient tissues. And X-ray source and detectors move through an arc of 180 to 360 degree to form multiplanar images. These images form the raw data, which are then reconstructed by means of software by computer algorithm to form cross-sectional images. So this, as I said, this is the image detector. This will be true for the conventional CT also. This is the gantry also. This is the gantry of the cone beam CT. But then if there is a conventional CT also, this works in like this only. This will be the X-ray tube. This will be the image detector. If you are using a conventional sort of a, if you are doing a conventional CT scan, then it will not be in the form of a cone. It will be much wider. The X-ray projection will be much wider, and the image detector will be much bigger. So these are some examples of the images that are produced by the cone beam CT. This I have already discussed. So these are also, this is a 3D reconstruction of a cone beam CT scan. So what are the components I have already discussed? This is X-ray generation, X-ray detection by the image detector, and image reconstruction. And images formed can be, they can be either two-dimensional, three-dimensional, or combination of both. Now, uses of CBCT in general, because see, basically CBCT was basically brought for the dentists. So you will find that most of the indications of CBCT are the dental indications. It helps in tooth decay, detecting tooth decay, bone loss, abnormal bones, facial fractures. Facial fractures, even ENT specialists are handling. So facial fractures is one thing in which the ENT specialist would also be helped by a cone beam CT. Periodontal infections, irregularities of the TM joint. We also, ENT specialists also encounter TM joint abnormalities and problems with tooth roots or dental pulps. Now, ENT, how it is used in ENT, head and neck, in head and neck reconstructive surgery, you can use instead of going in for a traditional CT scan. For sinuses and nasal foci, inflammatory pathology, fungal sinusitis, dimensions of the cochlea. To know the dimensions of the cochlea and the position of cochlear implant electrodes in the inner ear after the cochlear implantation. And 3D CBCT scillography in imaging of a non-cancerous disease study of tooth sinus lesions and bone remodeling and mucosal calcification. Now, what are the advantages? The main advantage is reduction in radiation dose. And the rest of these advantages are also afforded by the high resolution CT scan, that is rapid scan time, beam limitation, image accuracy, interactive display mode, multiplanar informating, three-dimensional volume rendering, good spatial resolution, economical, comfortable, safe. But reduction in radiation dose is the actual sort of
advantage of CBCT over the traditional CT scans. Now, there are certain disadvantages also. Sometimes there will be poor contrast resolution. Incidence of artifacts are more with cone beam CT, and there is an image noise also. So I come to the end of my presentation. Recent advances topic. This is sky is the limit. I think I'll be taking another lecture next week or whenever DNB NB asks me to take. So this is just a list of the books or the journals which you should consult for further reading. Uh, these are all standards. You must be reading all these textbooks and OCNAs. Catch hold of them, of these OCNAs, and make some notes out of them, so that you, whatever recent advances you get in your papers, you can answer them. So thank you for your attention. That will be all for this day, for today.
Thank you very much, Dr. David. Trainees, you may type your questions, comments in the chat box.
Thank you, Dr. Divya. It was a very dry topic and you really made it very interesting and covered a lot of things. And definitely the
recent advances is one thing. Nobody can cover everything. There are so many recent advances. What I have done is that whatever is available in Scott Brown or in Cummins, I have not covered that because the textbook is there. But then these are the topics which are not there directly. Indirectly, there may be there, or in some chapter there is something, in other chapter there is something. So these topics are basically hot topics, and most of these topics that I have covered questions have come even in the theory papers, and in Viva also people do ask these questions from these topics. So I have covered these
definitely.
Topics.
So these the small bits of information, they are very valuable for the candidates, and I'm sure they would have benefited from your talk. And in the next, I think next Friday, you will cover many important topics as well.
Yes, ma'am, I shall say follow the same protocol, and I shall only cover those topics which are not directly there in the textbooks.
Yeah.
And that I'll do, because in the textbooks it is quite lucidly written. There are boxes, etc. So the candidates can very well go through those textbooks, but then there are topics which are not given in textbook, but which are relevant for the exam point of view also.
Yeah. Are there a couple of questions, I think, in the chat box?
Yes, let me know them.
Mr. Navneet.
Dr. David, are you able to see the chat box at the right bottom?
At the right bottom. No, unfortunately. There is a Q&A, yes, there is there, but then I cannot see any question.
Look the chat box, the chat.
Chat box, yes. Yes. Achha, the question is that site of TCRFA for terminates all along the terminate or only in the anterior end? No. See, there is a special probe, whether it is the TCRFA probe or whether it is the coablator probe. What happens is that you have to enter just like how you are doing traditionally. See, what you do is, in the old days, what you used to do was we used to insert a LP needle and then pass the monopolar, and then we used to sort of take out gradually the needle, and it used to, as it was coming out, that energy from the electrocautery would, shrink the tissue, the submucosal tissue of the terminates. Now here it is almost the same in TCR, whether it is TCRFA or whether it is coablator. Basically, there are probes. In fact, for TCRFA, there are bipolar probes also. So you put in that into the submucosal space and you go up to the end. And mind you, there is one important thing you must notice. This is the practical tip. When you have inserted the probe all through and through, just take your endoscope. You must be doing it under endoscopic guidance. So whenever you are taking the you are inserting the probe, just check whether there might not be a double puncture. But you have to go up to the end of the submucosally, up to the end of the terminate, and then press the radio frequency or coablator, whatever it is. And then it is not that continuously you are taking it out. Just wait
3 seconds, total of 10 to 20 seconds is the time which is recommended by most manufacturers. So 2 to 3 at each point. When you are withdrawing it, withdraw a little. In fact, the collator probe will have markings on it. So you take out up to that marking, the probe, and then you wait for 3 or 4 seconds, pressing the collator foot pedal, and then you take out another, some more, and then you wait. So it is the whole of the turbinate that you have to radio frequency, you have to sort of reduce volumetrically. So applying it on the anterior end will not serve the purpose. Basically, it is the whole turbinate which is causing the nasal obstruction or the snoring or whatever. Please explain stroboscopy. Now, I didn't cover stroboscopy. I will require one more topic for stroboscopy. If you are in OCT, please go through the Scott Brown. It is given very well in that. I don't think I should be covering. See, my aim is to cover those topics which are not given in Cummins or Scott Brown. I think whatever has been given in Scott Brown is quite, our Cummins is quite exhaustive and put in a good manner. Now, if there are specific questions, I can go into that. Will we get recordings and slides? Now you have to request Navneet ji and Dr. Nilima madam for this. I am not the authority to take a decision regarding that. I've got no objection to my slides.
Back to Mr. Navneet, and I think only he can help in this regard.
So you can write to NBE if you want this.
So we encourage trainees. We encourage you to participate in live lectures and ask questions. However, recordings will be available on the NBEMS website. You can log in with your registered email IDs, and you can see the recordings.
Okay.
Yeah. So thank you, Dr. Divya. I think we should end this session now. Thanks a lot.
Okay.
Thank you, Mr. Navneet.
Okay, ma'am. Okay, Navneet ji.
Thank you
see you
much,
again.
Yes. So thank you very much, Dr. Divya Aggarwal, for the presentation, and thank you very much, Dr. Nilima Gupta, for joining us. And thank you, trainees, for joining us.
Okay. Thank you. Thank you so much, everyone.